episode of Vein and Lymphatic University. We're happy to have everyone here, as well as our distinguished panel, which I will introduce in just a moment. I am filling in for Sarah Oneida, who is the main moderator. So I just ask that everyone bear with me for trying to share my screen and managing the Q&A. Sarah is taking her boards today in the UK. So right now I will share my screen. Let me see. Is that showing correctly? Great. So again, we are Vein and Lymphatic University, and in just a moment, we will show introductory slides. I would first like to thank our generous sponsors, Medtronic and Boston Scientific, for helping sponsor these webinars, as well as the university. Before we do the introductory slides, I'd like to introduce our panelists. Today we have Dr. Paola Ortiz joining us again. She's an associate professor of phlebology in Uruguay. She's trained in various endovenous treatments, microphlebectomy, and she has also been to NYU School of Medicine training under Dr. Lowell Kabnick. We have Dr. Luan Lam, who's a podiatrist and a board certified wound and lymphedema specialist, as well as a hyperbaric physician. She's the corporate-wide medical director of wound services for United Vein and Vascular Centers, which is a private multi-state surgical group specializing in offering integrative vein, vascular wound, and lymphedema programs. We have Dr. Suzanne Ehmann, who's a clinical specialist of edema and lymphedema management at Stanley Regional Medical Center. She's also a certified lymphedema and wound specialist and certified lymphatic therapist in Albemarle, North Carolina. And we have a presentation, but not able to join us, Dr. Pauline Raymond Martimbeau, who's a phlebobologist in, that should be Dallas, Texas. She's the past president of the Canadian Venous Association and founder of the Dallas Non-Invasive Vascular Lab and director of the Vein Institute of Texas. She's has served as the vice president of the UIP as well. So now I will unshare my screen, and I'd like to have the introductory videos from Dr. Kanata and Dr. Kabnick. Thank you.
Buenos días, queridos amigos. Yo soy el doctor Víctor Kanata, presidente de Vein and Lymphatic University. La plataforma y el grupo de trabajo de Vein and Lymphatic University es un grupo de profesionales de alto nivel, a nivel mundial, que se encuentra desarrollando programas de enseñanza, de capacitación y de preparación de diferentes tipos de webinar, trabajos humanitarios y enseñanza en el campo de las varices y los linfáticos. Este grupo de trabajo tiene una calidad y una capacidad excelente. Nos encontramos permanentemente trabajando en demostrar la excelencia y la capacitación de todas las personas dedicadas al tratamiento de las varices y de los linfáticos a nivel mundial. Por eso les decimos y les agradecemos al grupo de trabajo. Les pedimos que nos sigan en nuestras plataformas y en nuestros diferentes webinars y que se acerquen al grupo de trabajo de Vein and Lymphatic University. Generalmente lo manejamos en forma compleja, teniendo la posibilidad de demostrar el trabajo de las diferentes diversidades tecnológicas, demostrando las capacidades científicas a nivel mundial. Así que, por tanto, les doy la bienvenida y espero que nuestro trabajo tenga sus frutos en relación a la capacitación, la calidad de la enseñanza y así como también la llegada a nuestros diferentes pacientes a nivel mundial. Así que un fuerte saludo para todos. Por favor, recuérdense de que la capacitación y la enseñanza es algo que realmente nos va a ayudar y va a demostrar que nuestros pacientes cada vez reciban mejores diagnósticos y mejores tratamientos en el arte del tratamiento de las varices y los linfáticos. Un saludo para todos y que Dios los bendiga.
Right, and if we can play the video from Dr. Cabinet.
Hello, everyone, and welcome to today's session. My name is Dr. Lowell Kabnick, and I'm the chairperson of Vein and Lymphatic University. VLU is a premier educational platform whose mission is to deliver groundbreaking, high-quality content utilizing the talents of a diverse global team of health experts focusing on venous and lymphatic disease and treatment for the medical community and its patients. The goal of VLU is to make a positive impact on the global medical community by accelerating venous and lymphatic education through highly accessible and interactive live webinars and lectures, informative videos, and other premium channels of community engagement with the aim of empowering, inspiring, and advancing understanding of venous and lymphatic disease and treatment. Our initial series is titled EmPowHER, which was developed by Ruth Bush, Sarah Oneida, and Leanne Alizio. This is a series of webinars crafted and directed by our women colleagues for all. On behalf of VLU's Executive Board, we thank you for joining us.
All right, wonderful. So I realized listening to that I never introduced myself, and I know my background is very dark. I am Ruth Bush, located in Houston, Texas, again, filling in for Sarah Oneida, who is the main moderator. So we have our panelists here, which I had introduced. So let me just sort of have you give a wave to our audience. I'll just start at the top. Dr. Luann Lam, who is in Tampa, Florida. Dr. Paola Ortiz from Uruguay. And Dr. Suzanne Ehmann from Albemarle, North Carolina. So thank you all. So let's get started on talking about venous ulcerations. For anyone who has a question, please put them in the Q&A and I will try to moderate that as well. So let me share my screen again and we'll get started. So you can see that, case number 1? Great. So these were provided by Dr. Oneida. The first case is that of a 78-year-old man, so a typical patient we might see, who has ischemic heart disease. He also has chronic obstructive pulmonary disease and is a longtime smoker. He has a 20-month history of having a right leg ulcer. This is just a example picture. That came about after he fell. He has just received compression in community care, nothing prescriptive, and has a long-standing history of skin changes, including ones you see here with dryness, scaliness, darkening of the skin, and some thickening. He is on multiple medications, including cardiac pharmacotherapy and inhalers. So why don't we just start, and I'll just ask you, Dr. Lam, what would be your initial approach? This patient is sent to you and you see these types of patients, I'm sure, frequently in your clinic.
Yeah, so I think one of the first things that we always try to look at when we see one of these patients that has had issues for so long and also have had a lot of trauma is just kind of what their what their social situation is like. Are they at home with people who could help them? Are they constantly at risk for falling? And then also what kind of, he's been receiving compression. So what kind of compression has he been receiving? Has it been good quality compression? You know, with the compression, has it limited his mobility even more? So I tend to, you know, look at some of the social aspects of the patient first, because sometimes that also kind of guides us in tweaking what else to kind of to do for the patient. Obviously, you know, looking at his smoking history, trying to reduce reduce his smoking, putting him on a program of some sort. And then, you know, when we're taking a look at his ischemic heart disease, the question is always, what's his flow like? Are his ABIs adequate? Are his ABIs adequate enough to receive, you know, good quality compression? So that would be at least like my initial look at just his medical history and his social history. And then how much is he using those inhalers? Likely prednisone based inhalers, steroid based inhalers. How much is he using it? If he is, that could also affect kind of the quality of the skin and of his healing. So that would be kind of my initial look at least his like medical history there.
What has, let me just ask you a couple of follow-ups, and then I'll move down our panel for their ideas. Is with someone who is 78 years old, and you mentioned the social issues surrounding it, one of the problems that I see is number one, you talked about the mobility problems and being a fall risk, maybe looking at his frailty index, but how successful have you been with having patients who are elderly be able to don stockings? And you mentioned good quality stockings. What would be the definition of good quality?
Well, if his mobility isn't, if he's always at a fall risk, I mean, one of the things that we always try to do is get home health involved, get his right for physical therapy, for a fall risk assessment at home, and put him on some sort of gait and balance therapy program at home. Making sure that he's actually, if he's got some sort of walker or cane that he's using, the question is always, is he actually using that walker, that cane? And then, you know, depending on how good his mobility is, I found that a lot of these patients, it's sometimes it's not a problem of whether or not they can actually you know, walk, but it's also a question of whether or not they feel comfortable even bending over in order to don these stockings. A lot of times, especially if he's got COPD, you know, they start bending over, they start coughing right away. So it's very, very difficult for them just logistically to bend down, put something on. I like a lot of the Ulcer Care compression stockings where it's Velcro. But, you know, again, some of these patients, it's just physically impossible for them to even just bend over long enough to be able to don those things quickly enough. So if his mobility isn't great, these are the types of patients that I actually like to wrap in the multi-layer compression wraps instead of having them in just a instead of just in you know, a compression stocking, at least for a little while. And then as we put them onto like a good quality gait program, then they can possibly work up to the point where, you know, we can get their mobility better to don some of these stockings.
Those are some great points. Thank you. Dr. Ortiz.
Hello, good morning, and thank you for the opportunity and for the invitation. It is an honor to be here. So regarding the patients, first of all, the venous leg ulcer are complex disorders, and it is important to, when I first face a patient, I like to know a lot of detail about the history and also the ultrasound. For example, in this patient, we have to think about the artery problem. If there is a ankle brachial index less than 0.8, we have to think about artery problems as well, because there is not, so the venous ulcer account for the 80% of the ulcers, but there is a 20% that are involved other problems like artery problems or something else. And so it is important to also know that there is a 50% or 70% of recurrence after a treatment. So we have to think about, when we first meet the patient, about all the details, the arteries, the body mass index, the mobility, and also look for all these problems during the examination. So the ultrasound, look for the superficial system problems or deep system, and also artery.
Thank you. Dr. Ehmann.
Yeah, so I'll kind of weigh
attention of this detail, like
and I'll weigh in and kind of tag team maybe off of what the other two physicians have said. And I think one thing, it's a little bit, I know this picture, they said it's just from the internet, but I think far too often we just focus on the wound and not looking at the rest of the patient. So certainly you'd like to see kind of what the rest of the leg looks like. What is their mobility? Dr. Lem has already pointed out, it's not just mobility, but range of motion that really speaks to the calf muscle pumping, the ability to activate that venous system. I agree with Dr. Lam. My first step would always be to kind of take a good assessment of the vascular status in order to apply compression. But I think there's a lot of good compressions out there with a lower resting pressure. If you do have somebody who has a modified or a lower ABI, that you can do a modified approach to compression for this particular patient in the short run. So a lot of times I'll start patients on a 2-layer wrap in order to get that healing process going before I switch them over to any kind of self-application. As far as stockings, I think one of the things people are not aware of is there's lots of donning devices that are out there. So I've taught, an 89-year-old how to put a flat neck garment on. And so I know, 89 years old, it kind of goes back to where there's a will, there's a way. And for me, my top things is to get my patient engaged, and that is education. Explain to them why they have a disease or why they're having this ulcer and why this ulcer has not healed. Highlight for him, okay, you're a smoker. Did you know that decreases the blood flow to your healing your wound, right? And so explaining that to patient in terms that they can understand, engaging them, bringing them back sooner. I know in the US, I think we have a multi-country audience perhaps. And, in the US, the business model really is put something on and have the patient come back in a week. Well, maybe that first week, have the patient come back in a couple of days so that they can really see that wound is looking better. And by engaging the patient in that problem solving, okay, this isn't, I'm not going to fix you. You need to fix yourself. We need to get you more mobile. We need to tighten up your medical regimen. You get rid of your comorbidities. And we're going to use compression in order to heal, because what caused this wound? And Dr. Ortiz definitely made a great point that a lot of times it's not just venous disease, that these are multifactorial, but, breaking it down for the patient and explaining, okay, which of your comorbidities can you address, right? And then which one am I going to help you address?
I like that. I think you all make very good points about getting the patient involved in their care as well, and seeing, what they bring to the table. So this patient comes in, you've got, what we see as some signs of chronic venous insufficiency. I'm going to give you, your test results in just a moment. But what if this were bigger? Usually we see oftentimes bigger wounds that are draining, that have slough on top of them, slime. They smell. What would you all describe your approach to those wounds, even if you're not sure you can feel pulses? The patient has a history of arterial disease. What is your approach to those wounds that have just been really neglected?
I can go I actually start looking at, I mean, if you look at like his skin changes, you know, there's probably at least like a safe assumption, somewhat of a little bit of phlebial lymphedema involved. And with the thickening and the eczema, you know, I always tell patients that I want to treat the skin around there sometimes first before, you know, we really even look at the actual wound itself, because the peri-wound area is what you're the skin that's surrounding that area, you're wanting that wound to heal up. And if the peri-wound area looks terrible, your wound as it heals up, it's going to look just as terrible. So, you know, I start looking at the eczema involved and addressing that portion of it. A lot of times, if I know that we can't do compression just yet because we don't have studies just yet, I'll actually have them do some sort of a Purifion zinc based shampoo wash on their legs, just plain old Head and Shoulders. And we tell them, you know what, treat your legs just like you would dandruff on your head. You know, it gets down a lot of like the scaliness, it gets off a lot of the treats a lot of the itching. It's still somewhat antibacterial, it's still somewhat antifungal. So it also, you know, to Dr. Ehmann's point, it also kind of involves the patient a little bit more. You know, it's a good way to actually assess what their buy-in is. If they can't go out there and just do a week of buying a cheap bottle of Head and Shoulders shampoo and washing their legs, you know, it's pretty much a good assessment of like how involved you're really going to get that patient in. One of the best things about that too is that after about a week of just doing that and getting that peri-wound skin looking a little bit cleaner, the patient will see pretty much right away that there's some level of improvement. And that in itself, especially if he's been dealing with this for about 20 months, that in itself sometimes increases that buy-in for patient compliance. And then as we're looking at some of the, you know, the thickening, the scarring around there, this is where, you know, Dr. Ehmann's expertise would definitely help out with like the lymphedema, self-MLD therapy, just a little bit of massage therapy. And again, that also kind of increases their buy-in until we can actually start looking at something a little bit more aggressive for the actual wound treatment itself.
Well, that was worth the whole webinar. I'd never heard of her doing Head and Shoulders on the peri-wound area. That's fabulous. Thank you. Dr. Ortiz.
Yes.
How would you treat the wound?
I agree with Dr. Lohan about the skin around the ulcer. It is important to take care. I like to give some vitamin A, steroids. There is a lot of inflammation that may help with also the itching that the patient used to increase or you know, scratching that. And also them to, after ruling out, in this case, for example, the artery problems, I will put on compression, a lot of compression. And also if the ulcer is dry or is exudating too much, so I will use different dressings. But compression and treating the reflux behind this, beneath this, is the most important for me.
All right, thank you. Thank you. Dr. Ehmann, anything to add?
I put a couple of things in the chat box. You know, for me, it's all about, I live in the rural North Carolina region. We don't have a lot of access to different products and specialties other than kind of, so I want to keep it really simple. And so I go back to plain old fashioned soap and water really works. Unfortunately, a lot of these patients who have been in compression, they haven't had the opportunity to take a bath. And so just educating the patient with regards to hygiene. And there are studies when we look at even with lymphedema, those elephantiatic limbs, that just providing good ways for hygiene, soap and water, that you will improve the edema management and improve the appearance of the tissue. If you go back to your basics of wound healing way back when, and I don't even know when the TIME, T-I-M-E acronym came about. I know they revised it recently to timers. But TIME stands for tissue, infection, moisture, and the edge. So tissue. We want to get rid of any devitalized tissue. So a good old-fashioned wound wash. So like everybody has already talked about, manage the skid around the wound, but then clearing away the bioburden on the wound surface. If you have access to those couple of the different wound washes that are out there, are we allowed to talk names, or do we keep generic, Dr. Bush?
You can say what you want to.
Okay.
Educate. It may be, if you could, even if it's a trade name, say what it is, because of people in different countries may have different product names.
Yeah, you've got Vosh, you've got Anicept, are great products that you can cleanse the wound bed with, and to help to kind of break down that bioburden. But a lot of times you may not have access to that either because you're in a rural area. So plain old fashioned soap and water. Certainly if you're in an area that you're worried about the appropriateness of the water, you can boil it. There's recipes online to make saline that you can clean the wound bed with, and then getting rid of the devitalized tissue. If you're in an area and you can get like a mechanical debrider like Debra Soft, is wonderful to help if you're not of the skill set or don't feel comfortable with debriding the wound. So we know that we need to get rid of the bioburden that's on the wound surface, but if you're not skilled in that skill set, then Debra Soft is amazing. That's a product by Lohmann and Rauscher to actually get rid of the devitalized tissue of the wound bed itself, as well as the peri-wound around. And then, manage any infection, moisture. People, it's a little frustrating to me. I'm passionate about compression, and people talk about, oh, you can put this super absorbent product on, or we can layer this and that and the other. But don't forget about what's causing that exudate. So that weepiness of the wound is because the interstitial tissue pressure is high. If you don't combat that, then it's going to continue to pour. So yes, we need to address it and put a dressing on to manage that exudate, or the wound will get larger because the peri-wound is going to break down. But again, knowing compression, it's not about how tight you put something on, but about how stiff. And if he's got mixed disease, that's what's great about really knowing a little bit more about compression and how you're incorporating it for a patient like this is you can put on a product that is low resting pressure, but high working pressure. And it's that working pressure that makes compression work. So I don't know if that was.
Yeah, I would definitely agree with that.
That's great.
I found that a lot of our patients, if they've had bad experiences with compression, I'll actually have them come into the clinic a little bit more often, twice a week to 3 times a week sometimes, for the first maybe 2 weeks. Before then I turn them over to home health or drop them back down to a week. But if they, if we can get them onto actually a lower level compression initially, and then put them on a walking program. So I'll put them on just something that's about, maybe 20 or 30 of compression, millimeters of mercury of compression initially. So dropping down the compression a little bit, but making sure that we've got good quality, even compression. And then I put them on a walking program. So almost everyone these days has some sort of phone or an app that they can use, or a pedometer or a Fitbit. And we just start them off on saying, I just want 100 steps of intentional walking. And that's not just going from, from your couch to the bathroom or the couch to the kitchen, but getting up and saying, I'm going to walk 100 steps. And we start them off doing that twice a day. Once they master that every single day, twice a day, we tell them, okay, next week, jump it up another 50 steps. And so it kind of gives them a little bit of homework to do. You're getting that walking, you're getting them comfortable with using a compression, some level of compression, as well as, getting some of that active walking compression as well. So.
These are great ideas, doctors, and I've taken lots of notes. I'm going to let you know what comes next. So you are treating the wound, and you get a duplex ultrasound, and this is what you see. You have an incompetent cath perforator, and you see a venous plexus underneath the ulceration, and an incompetent greater saphenous vein. That's probably enough information, don't need any more details. what would be your priorities in intervention and your timing, and in terms of the wound and the wound healing? When would you recommend to the patient after you do your wound care or as you're doing it? So I'll just start with Dr. Ehmann.
I guess I would start with the other one because I can't do vascular procedures, but I really believe it should be a combined approach in the sense that it's not like you're going to wait to start wound care before you get, if you're able to address this and referring this out to a vascular interventionalist. I know here where I am, it takes time to even get an appointment. So I think you start day one with getting your basic assessment of what your arterial status is, because certainly we don't want to cause additional trauma by applying compression that the limb can tolerate, number one. Then number two would be go ahead and start good basic wound care. Clean the skin, clean the wound, prepare the wound bed preparation, and then get compression on the limb, good quality compression, low resting, high working pressure, and then make the referral out to a vascular to evaluate if there's any interventions that can be made. And I'll leave that to the specialist as to which interventions they would do.
Okay, thank you. Thank you, Dr. Ortiz.
Yes, well, I agree. I think that the plan is to, if possible, to do both things at the same time. So begin with a good plan of dressing and compression. Think about if the patient has a good compliance with the compression. Give them a good option, like maybe the silk with the Velcros, something that the patient can tolerate the good dressing, but go and do the treatment to the great saphenous vein incompetence with, depending on the size of the vein and everything, we have different tools or different devices to perform an ablation. And I think that this is the most important to treat the underlying cause, which is the venous insufficiency. So treat the great saphenous vein insufficiency with laser, radiofrequency, or no thermal non-tumescent ablations, and also the perforator. And always look if there is look for venous bed under the ulcer, and I like to treat them with ultrasound guided foam sclerotherapy. And sometimes I begin with this and also make a plan to treat the whole insufficiency. But this make a difference, a big difference, and also depend where you are. If you are in a hospital, in a private place, and also in a humanitarian activity, where sometimes you have all options, sometimes not. And ultrasound guided foam sclerotherapy to decrease the hypertension, the venous hypertension, will help a lot. And follow these patients with compression and dressings, good dressings, and this patient will, do well with only a few, or if you treat the insufficiency underlying. So I think we have to address everything and address the whole patients as well, the mobility, and if the body mass index is bigger than 25, we have to put them on diet, or connect with a good team. It's good to work with a good team of specialists to, and have a good rapport with the patient as well. This is like a combination of action we have to think about with the patient. But of course, to treat this incompetence is first, if possible.
Wonderful, thank you. Dr. Lamb.
Well, I'm a little spoiled because I work in a vascular vein center. So our wound center, we try to basically treat everything, as much as possible, as quickly as possible, all at once. And so I will usually work with my vascular surgeon to kind of plan out the timing of this, so that we're still doing compression, we're treating any underlying infection, we're treating the biofilm, and then more or less plan for any of the ablations or sclero to be done concurrently with wound care. So we try to, get the patient in and do everything kind of as quickly as possible all at once, as long as there's no raging infection that we have to worry about. So.
All right, excellent, excellent. I have one more question, and then we will move on. What about the role of biologics? And that probably is for you, Dr. Lamb. I don't know, Dr. Ortiz or Ehmann, if you all use biologics or have experience.
I love using biologics just in general. I think that there's but I think the timing of the biologics is really kind of the important thing. So regardless of what you put on for a biologic, what biologic you use, if you don't treat the underlying issues, then you can't. That biologic isn't going to take, regardless of the expense or type or whatever. And we tell patients, it's like if you put a piece of sod down on your front lawn, but your irrigation system and your sprinkler systems are still going off, that sod is just going to never take. So, the biologics that we use, unfortunately, here in the U.S., we're limited sometimes as to what types, depending on the insurance panels and what types of the timing, as well as the type of biologics that we can use. But overall, I think in most places, most physicians are going to be very familiar with a lot of the amniotic products. Those are probably the easiest to obtain these days. There's hundreds and hundreds of them, and it's always a question of whether to do a dehydrated versus a quote unquote live product. And so, I think it's also important that you kind of know, depending on the peri-wound, if you're also going to do that live or that dehydrated product. I've found that, for drier wounds, a live product actually takes pretty well. But that first dressing change, you're going to notice a little bit more increased hyperemia around the edges, around that peri-wound. And so you kind of have to also know to kind of what to expect when you're using a dried versus a live product. And so you may actually get more maceration than you would initially expect if you hadn't addressed that a lot of that drainage beforehand. But and again, I know we've talked about whether or not to use product brand names, but the ones that we've had and that I think are available, regardless of like insurance companies here in the U.S. are some of the ones from like Organogenesis, your classic Apligraphs, your Affinities, that sort of thing. And then in the mimetics category, that's your Epifix. So I think those are the ones that, they've been around for a long time. Everyone kind of knows a little bit more about them. But those are the ones we try to at least look at initially when we're looking at the biologics.
All right, thank you. Dr. Ortiz or Dr. Ehmann, anything to add?
I'll make a quick comment, and that would be, I think far too often, these are reserved in the US. You have to have demonstrated that you have had failure of conservative care. And I think it's really important that we've truly given conservative care. And I think far too often patients, again, they have this unrealistic expectation, oh, I'm going to get this graft and it's going to make my wound better. But go back to, if you don't treat the cause, it's not going to get better. And even if it gets better, it's going to come back. And I wish we would get away from, and I jokingly say that, grafts are sexy, they're exciting. They, have all this fanfare around them here in the US. You go to these conferences and they have the big, big boots and they're awesome and they're great. But I also think we need to have as much focus on that conservative piece, which is the appropriate use of compression and addressing the comorbidities that are contributing to the ulcer itself. If you don't have that other focus, that's the recidivism. So I just wanted to put the push out there for, you know, really understanding compression. And if you're using compression and it's not working, instead of maybe, you know, this first week or two, if you're not seeing improvement and you've done your vascular assessment, maybe switch your compression. All compression is not the same. A 2-layer is not a 2-layer is not a 2-layer. You know, we really need to look at understanding the benefits of each of their products. I always say there's something unique about all of the compression products that are on the market, but really trying to understand that and kind of picking and choosing based on what you see is happening in front of you. You guys do it all the time. I know you do, Dr. Lamb and Dr. Ortiz. You look at the patient, you do a treatment, and then you assess, you know, what's working, what's not working, and then thinking about how you can mix it up. So I just wanted to put a plug for, I know you're talking about cellular products, and I think they're great, but again, we also need to have as much focus, and we should be as excited about compression and compression options.
I would definitely agree about the compression component of it, because even when we're putting on a cellular tissue product, we're still also putting on some level of, we're still doing compression on that patient. And so it is very important to try to find something that works, something that the patient can tolerate, you know, before we actually do an application of a product. But I do think that, you know, what we found is that if we've had a lot of these wounds that have been kind of stagnant for a long time, there is a place in there for cellular tissue products to kind of just jumpstart a little bit of the wound healing. And, you know, I think, again, when you're talking about kind of the patient buy-in to it, you know, I usually will lay out the whole entire game plan for the patient so that they know that we're not just doing the same thing all the time. We kind of lay out what the benchmarks are and what we're looking for, you know, the amount of healing we would expect from just compression therapy and good skin care before we move on to that next level. And I think that also helps out, like I said, with some of the patient compliance and the buy-in to your plan of care.
Yes, I agree with all. And also, I always check again with an ultrasound to the patient and the follow-up. Sometimes the patient needs another treatment of the insufficiency. It's only not on, sometimes that procedure failure, or there is another perforator that we didn't see first, or is something new regarding the venous hypertension, and maybe the patient, before thinking about graft, think about the another cause behind, like venous hypertension. So that's why I follow up the patient with an ultrasound every time I see them. And if there is something I inject, or I treat the great saphenous vein with ablation again, depending on what I find. But sometimes this is one of the causes of the recurrence or the not improvement.
Can I ask a question to Dr. Ortiz?
Yeah, sure.
Okay, so I was going to say, can you comment on just the ability to visualize the anatomy in someone who is very edematous? And so I really appreciate your point of kind of going back and looking and see, do you find that if you have a patient that is very, very edematous, that it's difficult to appreciate the anatomy, and that there might be some benefit to, you know, once you reduce them, then send them for vascular assessment?
Yeah, sorry, I don't know if I understand exactly your question. The patients sometimes are challenging because of many things, not only because the anatomy and everything. It's like you have to take time with the patient for everything, for speaking about what is causing or how is their life at home, what they do, what they're not doing, what if they are resting or, you know, or walking or not. Calf. Also, the muscles, the calf muscle are really important. I pay a lot of attention about that, and I encourage the patient to do exercise and improve their muscle, the calf muscle. Sometimes it's a calf muscle problems, and maybe the hypertension, the venous system looks good, but the muscles are so weak, and sometimes improving this is, you will improve the healing process as well. And yes, about there is a lot of complications or difficulties during examination as well. So we have to find a way to, put the patient standing. Sometimes it's very difficult to make them to move, but look carefully for all the system is important, and also all the whole history and complaint of them.
Wonderful. Dr. Lamb, I see your hand up.
Yeah, I'll comment on a little thing that we do in our clinic. And again, I am very spoiled in that I've got RVTs and I've got our vascular surgeons there. But if one of my RVTs tell me that patient's too edematous for them to really get a good study, we have lymphedema compression pumps actually in our clinic. I'm sorry, the RVT. I see the question there. The RVT, the vascular techs or the ultrasound techs. If they tell me that they can't do a good scan on a patient because they're way too edematous, we actually will put them on a compression pump. If they've got, especially a gentleman like this, where if his ejection fraction is high enough and we know he can tolerate it, and he's not an active CHF, that day before they get the scan, we'll actually have them come in, put them on a pump for about half an hour. And I might, I play around a little bit with like the different settings on some of the devices, and I'll turn it up to, like, say, a focal or a clearing mode. And depending on where we're looking for certain things, if the tech is looking for, say, another perforator in that area where a medial malleolar ulcer is, I'll do a focal therapy on the compression pump for about half an hour, and then right afterwards, the tech can then see quite a bit more. In their they do a better quality scan.
This has been tremendous, doctors. I've learned a lot about wound care, and as you all know, these are the best patients. If you can heal that wound, they don't care about cosmetics. They don't care about what it looks like. They just want the skin to be intact. So I have learned a lot, and I appreciate your expertise. I want to move on to Dr. Raymond Martimbeau's presentation. I'd like to give another shout out for our amazing sponsors, Boston Scientific and Medtronic, who have really been generous in their support of the EmPowHER series, which allows these amazing women experts and panels from an international perspective to be able to comment. So if we can play Dr. Raymond Martimbeau's presentation. And again, thank you all.
Hello, everyone. I am Pauline Raymond Martimbeau, and I'm very happy today to discuss sclerotherapy, an integral part of venous leg ulcer management. Economic and social burden to the patient, the care team, and the healthcare systems. A venous ulcer is an opening in the skin of the leg or foot in an area affected by venous hypertension and chronic venous insufficiency. Chronic venous disease leads to approximately 80% of lower leg ulcers. It affects about 1% of the population, and this prevalence increases with age to 4% in people older than 65. Venous leg ulcers have a long healing trajectory. They're normally not painful, but they can be very debilitating. Vascular risk factors should always be evaluated, and arterial flow should be quantitated, as mixed arterial venous disease is common occurring in up to 25% of leg ulcers.
Not hearing the audio.
The borders, undermine the borders, and remove all the necrotic tissue at every patient's visit in order for the ulcer to reduce in size. Now, when there is a sign of epidermization, at that stage, the ulcer can be dried in order to create a good scarring and for the ulcer to heal. Complications of venous leg ulcer is very rare, and but when there is some sign of cancerization, it's important to get a biopsy of the wound. When it's infected, a wound culture and appropriate treatment. When the patient starts to get ankylosis of the foot, it's important to have them walk and have them very mobile. Sometimes there could be some calcinosis or eczema or hemorrhage coming from the surrounding tissue or the bed of the ulcer, and it's important to treat that as well. An important consideration is the use of compression. And of course, this requires patient compliance. So it's important to support the patient and explain how compression is mandatory in the management of venous leg ulcers. Now, the guidelines of the Society for Vascular Surgery and the American Venous Forum recommend a multi-layers bandaging, and this comprises of inelastic and elastic compression. Etiology management. If there is a venous disease that is suspected, it is important to assess the patient with a duplex ultrasound and treat the venous insufficiency. Now, sclerotherapy is a simple and effective, safe, and cost-effective treatment in the management of venous leg ulcer. It is an outpatient treatment that is easy to perform at the patient's bed, and normally the patient would accept this treatment over some other more invasive treatments. Performed simultaneously with the topical and conservative treatment, it helps the healing process and reduces recurrency. It's important to pinpoint where the incompetence is, or which incompetence is responsible for the ulcer. It's important to respect the golden rules of sclerotherapy, that is by treating the highest point of reflux. But sometimes there could be some exceptions where it is acceptable also to treat the surrounding incompetence in order to speed the healing process. If the duplex ultrasound determines that the insufficiency is located at the great saphenous vein, and if the reflux is larger than 0.5 seconds at the saphenofemoral junction, it is possible to treat that insufficiency with ultrasound-guided foam sclerotherapy. Polidocanol, 1% or 3%, sodium tetradecyl sulfate, and the concentration of 1% or 3% could be used according to the diameter and the degree of reflux. And the maximum volume per session should be limited to 10 to 15 milliliters. Now, it is important if the great saphenous vein is larger than 11 millimeters to consider alternative treatments. Perforators are often responsible for venous leg ulcers, and especially the coquette perforators. And if the perforators have a reflux of more than 0.35 seconds, they are considered pathological, and it's important to treat them. Ultrasound-guided foam sclerotherapy is an excellent and safe treatment for this condition. And again, polidocanol 1 to 3% or SCS 1 to 3%, keeping the volume at 1 or 2 ml per site. Always treat distally to the exit perforator. If the incompetence is due to a tributary incompetence, the treatment with ultrasound-guided foam sclerotherapy is an excellent choice, and it received the grade 1C evidence. Phlebectomy is also useful if the diameter is larger than 11 millimeters. Small saphenous vein is a incompetence that can often lead to a venous leg ulcer. And treating the small saphenous vein, one needs to know that the termination of that vein varies considerably. And venous ultrasound needs to be used to find the termination, which often it would be above the pulpital crease. And treatment with polidocanol or sodium tetradecyl sulfate in the concentration of 1% with a volume of 1 or 2 ml is a good option for sclerotherapy of small saphenous vein. Perforator of the popliteal fossa is often also associated with venous leg ulcer and can also be treated by ultrasound-guided foam sclerotherapy. Surprisingly, telangiectasia can also result in venous ulceration, especially patient with corona phlebistetica or patient with telangiectasia that carry a lot of reflux coming from saphenous vein or deep venous system. Sclerotherapy is an excellent treatment, taking in consideration the underlying condition. In conclusion, it's essential to identify and implement an evidence-based plan to correct the causes or cofactors that affect venous leg ulcers. Eradication of underlying venous incompetence and sub-ulcer plexus is mandatory. Sclerotherapy is a great option, and it's normally very well received by patients. Sustainability to support prevention and reduce risk of recurrency need to be assured. Further studies will help develop standardized protocol for faster and better outcomes. Thank you very much for your attention, and save the date for the Canadian Society of Phlebology meeting in April of 2022.
Excellent. I think that I think that this goes back to one of the acronyms that Dr. Ehmann put in the chat of keeping it simple, because I think that, and I would like to ask your opinions on the use of sclerotherapy, because it is cheap and it is available, and oftentimes our patients are in, say, rural areas, or they don't have insurance, they cannot pay for ablation, and I think about when I do humanitarian work in other countries, and all I have is sclerotherapy. I'd like to ask your opinion. I have not been as aggressive, perhaps as Dr. Raymond mentions in her presentation. I have not done axial veins And I've been a little remiss with foam sclerotherapy, especially in larger veins, because of the risk of embolization. And so I would like to ask the panel's opinion on that.
Well, yes, if may I answer, I have a lot of experience with ultrasound guided foam sclerotherapy. What my first experience was maybe in 2013. I joined the University of Wisconsin humanitarian activity in Honduras, and in 1 week we treat 1,500 patients in 1 week with ulcers and different things. And there was the first time I injected foam into the great saphenous vein for an ulcer. And I was surprised, and I'm still, because the ulcer healed, you know, when I follow up next year, because since then I'm joining them every year, and I can see how this we can change their quality of life. The ulcer heal with, you need more than one treatment. This is the only big issue with the ultrasound guided foam sclerotherapy. If there is a great saphenous vein, a big one, greater than 11 or 10 millimeters, of course, a laser or something is much better, but we know that as well, and the ulcer will decrease size and also the pain, and we can make a lot of things with this treatment as well. And so if we don't have another technique like a laser radiofrequency or a nocturnal tumescent ablation, it's a really good option as well. It is. And maybe you would need more than one treatment, but this is the only big, and there is no deep venous thrombosis. You know, the complications are low. I never had any complication during procedures like ultrasound guided foam sclerotherapy to the great saphenous or small. And the small saphenous respond very well. The closure rate at 5 years is really good with ultrasound to the small saphenous vein. To the great, it depends on the size, but you can treat the perforators and all these tributaries. And if you combine ultrasound guided foam sclerotherapy with phlebectomy, this is really great. The results at the end are really good as well.
That's great. Thank you. Thank you for your expertise.
You're welcome.
If I can comment as well, I found that in working with a lot of different vascular surgeons that some of the, sometimes when you have a really, really sick patient and, you know, even though you want to just fix everything, sometimes, you know, just fixing enough to heal the wound in a very, very sick patient is all you're really going to be able to get. And so this is where, you know, some of the vascular surgeons, some of our other general surgeons as well, you know, if they do just a focal therapy in the area, just enough to heal the wound, you know, sometimes it's just enough for that, the quality of life of that patient in order to move on to do other things that might be what's keeping them from getting a back procedure or a knee implant or something else that is also, you know, causing a lot of mobility issues. So sometimes even though, you know, we look at the patient and they need all of this stuff, sometimes, you know, you know, and again, kind of in keeping it simple enough to get them to another level. The sclero I found, you know, some good results with when our surgeons have been able to do it.
That's wonderful. And I think, you know, I think one of the things that I'm hearing from all of you all, and I'm actually then going to describe what the second case is rather than put it up there for the sake of time, is you're talking about patient involvement in shared decision making, which I think is incredibly important. And also thinking about what the patient quality of life priorities are. And so I really appreciate this conversation and what it has evolved to, because it's, you know, for surgeons, it's, you know, we have to consider that it's not always about doing an intervention. It's what you all have said is what is important to that specific patient. And so this question about the second case that Dr. Oneida sent me is a similar case. You can just imagine different age, different background, someone who's had a DVT, anticoagulation involved. At what point would you consider doing further studies? You're maybe got some wound healing, you've cleaned up the wound, you've done your compression, making some progress, but it's not completely healing. In patients who have a history of a deep vein thrombosis, one that was fairly extensive, at what point would you interrogate for pelvic obstruction or pelvic vein insufficiency? What would lead you to additional studies if you're not making progress? Dr. Ehmann, I'll start with you, or Dr. Ortiz, you were about to raise your hand.
Yeah. No, I like to think from the beginning. If there is some, if I have to think also in a deep post-thrombotic syndrome or an iliac compression or something, I like to ask at the beginning, the first time I met a person. But also, if the wound is not healing properly, I go and ask for a study of the deep system, the iliac, and sometimes also a biopsy, because there is more than one causes. The deep system account for, so a post-thrombotic syndrome is 20% of the leg ulcer. So it is something we have to take. But there is another, there is some other systemic problems that can also cause ulcer, like sickle cell anemia. So in those cases, I will do a biopsy, and if there is no, a risk factor for this, I will ask for a deep system ultrasound or phlebography.
And
Excellent, thank you.
I'll tag team and say, in lymphedema training, we always have a saying, look up. Far too often, I think in the wound care world, we get focused on just what's happening below the knee. And so it's really important when we do training for our lymphedema therapists, we really talk about taking, I jokingly say all my patients come in and take their pants off, because we're looking at both lower extremities and looking at it all the way up to the groin or all the way up to the nethers to see what else is going on. And do you see swelling? Is the thigh getting bigger? And so certainly to me, that signals that we need to look further. My go-to is, I want to see every single time that I unwrap that wound that it looks better. And if I'm not seeing progressive, I have a very short fuse, so to speak, or trigger, I guess is the better word, a short trigger to say, hey, let's involve somebody else. Because the patient's time is really important. It always blows my brain that patients are seeing a specialist for a year and the wound's not gotten better. And then you start saying, okay, well, have you done this? Have they looked into this? And it's like, no. Has anybody ever biopsied it? No. I mean, I'm a physical therapist, and I can't tell you the number of times that I've been the one that sent it off to dermatology and it's come back cancer. So, I mean, I think it kind of goes back to having that short trigger. And then the second thing I'll follow up with is, I have a lot of patients who you might send them to a dermatologist and they'll say, well, I don't want to do a biopsy because, typically you do the biopsy at the edge of the wound because you're trying to get some of the good tissue and some of the bad tissue so you can rule out what else is going on. I'm going to make another wound. And I always say, I can manage those wounds. I can manage the swelling, but if there's a cancer or if there's some other autoimmune disorder that's going on, if you don't get that part taken care of, what you're doing from the medical, or what I'm doing from my little world, my glasses on, won't really make a difference. So at short fuse, I say, if it's not serially getting better, or if I see that it's plateauing, then I'm definitely referring out. I'm looking up. If I'm seeing thigh swelling, I'm thinking, is there a proximal obstruction?
That's awesome. Thank you. Dr. Lamb.
So my MAs, nurses, they regularly, for venous ulcer patients, every single week that the patient is seen, we measure the circumference of, the foot, the calf, and the thigh and the waist. So they know that every single, that's part of what they do for vitals. And so that way we kind of early on see if the types of compression we're using or the procedures that have been done, if it's causing it to kind of back up anywhere else. And it's not always perfect, but it kind of gives you at least like a trend in seeing that, you know, that additional like thigh swelling is just not going down, whereas like everything else is going down. And, you know, I would agree with Dr. Ehmann about the short trigger. If you're not seeing at least like after they've had all these procedures and you know that you've done everything that you possibly could to kind of control some of the other factors, if you're not seeing at least like a 10% improvement in the size of the wound, or at least like the quality of the wound bed, every time that you see, every week that you're seeing this patient, then you know you definitely have to get a biopsy. You know, rule out the pyodermas, rule out the especially if it's a recurrent leg ulcer, rule out squamous, marginal ulcers. You just have to kind of make sure that you're seeing at least some level of, and 10% is kind of my general guideline week to week as far as like improvement.
All right, excellent. Well, we just have a couple of minutes, so I have one remaining question. Hyperbaric therapy. How often do you use it? Does it work? Does insurance cover it?
So hyperbarics is always kind of one of those, most people feel very strongly about it one way or the other. I've been in clinics with hyperbaric therapy available to me. I've been in clinics without it. We've been able to heal wounds without hyperbaric therapy. But hyperbaric therapy, you always have to remember it's an adjuvant therapy to everything else that you're doing. So it's not necessarily the cure-all for wound healing. For venous wounds, I haven't found that it's you know, you're not really getting a whole lot of benefit from hyperbarics for venous wounds. If you've got some sort of mixed disease, it could help, but you know, insurances are not going to necessarily pay for, there's no indication for venous wounds for hyperbarics from Medicare. If you're looking at, you know, it does actually help out with a lot of these, if you're just looking at hyperbarics just in general, like a theory of it for these chronic wounds, I mean, it will help out a little bit with increasing like the vascularity, but will it help it? Again, kind of weighing out having a patient come for 90 minutes to 2 hours a day, 5 days a week for 6 weeks or whatever, versus being able to get them out to do a physical therapy program, to, you know, walk more. You know, sometimes, you know that you only have that patient's attention for so long, and I don't know if I would necessarily use that my limited attention span right there to put them into like a hyperbaric chamber. So I think there are times for it if you're looking at you know, a significant gas gangrene situation, a significant diabetic situation where you are really worried about, you know, the vascularity to that area. But for a venous, just a regular venous wound, I would not necessarily recommend hyperbarics.
All right, thank you. Any other comments, Dr. Ortiz or Dr. Ehmann?
No comments.
Yeah, I don't have access. So.
Yes, and I don't know that I've ever actually gotten it approved. Well, we are at time, so I would like to thank everyone who's either on the Zoom or watching through streaming, Facebook or YouTube. Thank you so much for joining us this Saturday, November 6th, for talking about venous leg ulcerations. And we really talked a lot about wound care, which having Dr. Lamb, Dr. Ortiz, and Dr. Ehmann, who are wound and lymphatic specialists, this has been a treat. It's been very enlightening. It's given me a lot of things that I'm thinking, I can do this with my nurse practitioner or my PA to start thinking about, and other things that I can possibly do even when I'm going to other countries when we're allowed to travel. So I'd like to thank Dr. Kabnik, Dr. Kanata, and Venous and Lymphatic University for this opportunity and for the EmPowHER series, and our generous sponsors, Medtronic and Boston Scientific. Without you, this would not be possible. So again, Dr. Lamb, Dr. Ortiz, Dr. Ehmann, thank you so much. And we all wish Dr. Oneida the best on her boards today. Doctors, ladies, have a great day, and our audience have a great rest of the weekend. Thank you all.
Thank you so much.
Thank you very much.
Take care. Bye-bye.
Bye-bye. Thank you.